Welcome to the Progress Toward Deep Interoperability, a panel discussion with KLAS. Today we have Corey Tate, who is the Vice President of Research and Strategy. Corey has more than 10 years of KLAS experience leading various clinical areas of research. He currently heads research on acute EMRs and interoperability solutions. We're also joined by Tyson Blauer, Research Director at KLAS. He has worked with KLAS for 4 years and leads current research around integration engines and behavioral health EMRs. He also helps conduct research on acute EMRs and the broadening view of vendors facilitating interoperability. And then we have our very own Mohammed Shabli, Vice President of Solutions here at NextGen. For the past 15 years, Mohammed has been helping providers and healthcare organizations exchange data. Currently, he manages the application design, development, and implementation of the NextGen Healthcare Connected Health Solutions. So with that, I will pass it on over to Corey.
Thanks, Katie. Yeah, Tyson and I are really glad to be here with you guys today. I'm excited to talk about interoperability. Tyson and I are kind of the two-headed monster at KLAS that gets to try to wrangle this very, very broad term. And you know, we want to talk a little bit about kind of what we're seeing, some of the journey that we've been on, but again, really excited to be with you guys today and appreciate the opportunity. Just a little bit about KLAS. So KLAS has been in business for we've been around for about 20, I think it's our 25th year, 25th anniversary. But KLAS is kind of a different company. I mean, our mission is really focused on helping healthcare providers. So the goal really is around trying to provide transparency so that healthcare providers can make the best decisions that they possibly can, right? Have great conversations with the vendors as they're making decisions, and then end up with the solution that's going to best help them. And as part of that mission, we have for the past several years been researching on interoperability, and Tyson and I have been the head of that for about the last 3 years. We've been doing it for about 7 years, but we've come to kind of figure something out about interoperability. Is that interoperability is we think about it like the offensive line of healthcare, right? So an offensive line, you know, you never really hear their names. You don't know much about them. You really don't care that much about them. They're oftentimes not the prettiest people on the planet, right? And they don't get a whole lot of notoriety unless they don't do their jobs, right? When it breaks down, the quarterback gets sacked, or they get a holding penalty, right, in the middle of a play, the touchdown called back because one of the offensive line had a holding penalty. Then's when you notice it. And I think interoperability is very much kind of that same way. You know, as we get to real fluid interoperability, we won't notice it as much. The only time we'll really notice it is when it doesn't work. You know, when there's an occasional breakdown. Right now, it takes a lot of effort to kind of make things go for the most part. But I think we're moving towards a place where it really will become the offensive line and kind of just key to making our, you know, some of the big plays that we're trying to make happen in the industry, make those successful. So we're excited and for the future of what's coming on here. One of the things that we've noticed, especially over the last few years, is that interoperability has become it's just so widely used, right? It's such an umbrella term that covers so many different things. And we as an industry have tended to focus on this in silos, right? So we've talked about, or we've focused about on specific areas. So for example, meaningful use, when they talked about trying to drive interoperability, they talked just about sending patient records. That's what you were required to do, right? And I know we will sometimes see press releases from a vendor that says, you know, we do this X number of this type of a transaction, and therefore we're the interoperability leaders. There's a lot of talk about app stores. KLAS has historically focused on EHR to EHR record sharing, And that's what we've thrown that umbrella term on interoperability, on EHR to EHR record sharing. And now we've got the 21st Century Cures that really is focusing on patient access, right? That the patients have access to their information. And so what kind of happens is we throw out interoperability, and you can have such a confusing conversation because so many people are thinking about it differently, right? You end up like Mr. Bean here, where you're like, I'm not really sure what you're even talking about at this point. And so as classes, as we've thought about this, we've just put a kind of a high level, and this isn't like the official industry definition, but as classes thought about what we're trying to accomplish, really interoperability is all around data liquidity that's going to allow the healthcare to basically that empowers the concert that needs to happen, right? Because you've got to have patients and providers and payers all working together if we're really going to solve the problem and move some of the needles that we need to move. So it's a much broader term than we have traditionally ever really focused on in the past. And we realized last year that we were contributing to some of the confusion because we would pick an area that was part of kind of a silo under interoperability, and we'd go out and measure it, and we'd put an interoperability title on that report, and say, well, these vendors do really well, these vendors don't do as well, but there's so many other pieces in interoperability that maybe those vendors that aren't great at the piece that we were measuring may be the best in the world at some of the other pieces that are important. And so as a result, the last year and throughout this year, we have been working with the industry. We're working on creating a framework that's much more comprehensive, right? That looks at, and what it's trying to measure is, does your vendor provide the connections that you need, right? And make those affordable and relatively easy. And then not only that, but when you receive data, does the vendor that you're trying to use help you to be able to ingest that data and actually put it into the workflow and make it meaningful so that it has impact on whatever you're trying to do. And then are you getting to the outcomes and the use cases? Is it empowering the use cases and the outcomes that you had hoped that it was going to do? And so we at KLAS are kind of evolving in how we've looked at this. So there's still a lot of work to be done, but we're excited about the progress. And that's really what we're going to talk about today is some of the progress that we have noticed that has happened over the past several years. And Tyson, I think you're going to jump in and kind of run with this next part.
Yeah, for sure. So as we look at the research that we've done historically, the encouraging thing about it is, like Corey said, we have seen progress. We have seen the industry start to move. And I know I've had conversations with organizations who say we're starting to feel like that promise of interoperability is actually achievable, where before I didn't think we'd ever get there. So that's definitely something that's encouraging. And one of the first things that we've looked at that's really felt like we've seen that progress has really been around the connections vendors have made to Commonwealth and care quality. So as we go to the next slide, this is something that we get asked a fair amount about is, what's up with these connections to Commonwealth care quality? Are they competitors? Are they different? And really that they're working in concert, because care quality is a national framework. Commonwealth is a national network. The framework of care quality is helping to be able to connect disparate networks together to be able to share information back and forth. And we had a focus on doing this research primarily because this is something where there was low barriers for organizations to have to actually set up this connection. This wasn't something where you had to set up one point-to-point interface, or you're connecting into a small group of hospitals or a regional HIA or anything like that. It had a very broad reach and something that it seemed like it could definitely scale. And so as we kind of look at this, there are different vendors who have connected into, some said we were going to connect into Commonwealth, others said we're going to be using our networks and using the care quality framework. But where the magic really happened is when Commonwealth connected into the care quality framework, so that organizations connected through either one, through any vendor, are really able to share data back and forth. So that's been really cool to see this list of all the major EMR vendors saying, yeah, we are going to be connecting in, and we want our customers to be able to share data back and forth with each other.
Yeah, and I'd even say, Tyson, even add that, you think about this, and the biggest piece of this is, and Tyson hit on it earlier, is that this is the first time that the EHR vendors have been able to pretty much take the burden off of the providers and say, we're just going to enable you. You really don't have to do that much to make this, to make this happen. And you can, largely with the flip of a switch, it's almost a plug and play. It's as close to plug and play a piece of interoperability as we have right now.
Yep. And that's, if you go to the next slide, that's really what we've seen in some of our research is around the usability, because step one with interoperability is just connect me, give me access to the information. I can do the hard work to get there if it's unusable. But once you have that connection, it's a question of how usable is it and what's the effort that's involved to do this. This chart has quite a bit inside of here, but really what this does is this is summarizing to show what is it like to use data that comes in through this connection. Is this something where I have to manually decide, yes, I want to go out and find information. I need to manually make sure, is this the right patient that I'm looking at? Do I have to scroll through a PDF in a separate portal in order to find this information? Or is it something where, as Corey mentioned kind of at the beginning, this is back of mind. It just happens, and it's almost like magic where the information that I need shows up inside of my workflow, and it's not cumbersome. In fact, it helps me because I look and see, hey, there's information here about this patient that I didn't know before from somewhere external. And so all vendors are in a little bit of a different spot with this. You can kind of see on the far right-hand side there, there's the overall usability score where the different different vendors have done different those where they've made some parts more usable than others. They've had an emphasis in different places. But looking at those, the Cerner, Epic, and NextGen, you look at those scores, those are vendors who their customers are saying, this is pretty slick. This information is really just coming in pretty easily. We're not having a whole lot of issues with, we can't use the data. We can't pull out discrete fields. There's certain information where it's just really big pain to work with. Across this board, you look through the PAMI data, the problems, allergies, medications, immunizations, the labs, the progress notes. Really, these are just flowing in, and customers are saying, we're starting to see progress and think that this is something that's highly usable that we'll continue to use.
Yeah, and Tyson, just a point of clarification, this report, the reports we did on Commonwealth and care quality last year, were all focused on advanced users, so best case scenario. Right, and so there's a progress. Not everybody is taking advantage of everything that their vendors are making available. So as you look at this, and you might think, well, boy, my experience isn't like that. You may want to have a conversation with your vendor, because we validated that this is possible, and just look and see and work with them to see what you need to do to get to the level that you want to be at.
Yeah, that's a great point. And that kind of gets to the question that we've got for Mo here, which is, we've seen, if you kind of look at the historic reports we've done, that NextGen made some good strides in improving the usability of the data coming in through this connection. What is it that you did to kind of help with that? Because I know one of the things that especially comes up has been around duplicates, right? I get the information now. Yeah, it's easy, but I have a lot of the same thing coming in. What is the work you guys did there?
That's a great question. I mean, the data flow is one aspect of it, but actual usability is a top of mind concern for us and our customers. So one of the things that we did initially was really talk to clients and find out what are the challenges they were having with the documents that were already being exchanged. So across these networks, the biggest and most common exchange document historically has been a CCDA. And so before we designed any solution, we talked to customers. We asked them, what do you think about CCDAs? How usable are they? What are you doing with them? Where do they live in the patient's record? Who are the users in the organization that are interacting with those CCDAs? And then based on some of the information that we learned from customers years ago, we said, okay, we have to redesign how people actually view this inbound content. And so we built what we call the custom view, a custom view that takes all of the same XML content of the CCDA, but formats it in a way that's a lot more usable and gives customers control to filter and minimize the amount of data that's seen at any given time. So to address the issue of duplicates, the other thing that we did was we took the same content that we have today from First Data Bank, right? The medications and allergies and CVX codes lists that we get through our, medication dictionary provider. And we made sure that those same rules are applied on the clinical reconciliation and view steps that are initiated on that custom view of the CCDA. So for example, if a patient is prescribed a medication in the hospital, and that is the same or similar medication to something that already exists on the patient's record in the ambulatory EHR, if that CCDA includes that medication, we're able to identify that, yeah, that's a pretty close medication. That's a match. Maybe it's the same RX norm or NDC code. We also are looking at the dosage of those meds that come across, and we can use that information based on our FDB content and identify the ones that are duplicated or already exist in the patient's record. And when there is a match, not just on meds, but on, I think, 11 different categories of content, if there's a match, then we just show the user that this is data you already know about, right? This is data you already have, so you don't need to reconcile it. Your eye can just track down and find the items that are new to you and new for the patient. So it was really important to solve this problem. We had to work with customers and find out where their challenges were. And then we had to design a solution that actually works in the real world with the real world content. And that's when, we took kind of like a bulk amount of CCDAs early on and ran it through the custom view to see what would it look like, what kind of view would it actually produce for customers. And that was part of our process before releasing those updates. And, to see the result of that effort show up in a KLAS, research that, hey, we minimize duplicates for customers was a huge win for us. And our development and support teams really, feel very proud of the work that was done, but it's not quite over yet, right? So Tyson, to answer the last question on this page is like, what's next? And what are the usability improvements that we can keep working on? I think about, a common question we get from clients often is, we're still getting CCDAs, but where are the other documents, right? Where are the narrative notes? Where are the images? Where are, the text heavy descriptions of what actually happened? Whether it's in the hospital or in other care settings, today the care quality and Commonwealth exchanges don't always support and don't always include those types of attachments that are narrative and unstructured, documents. And so we're working with other exchange partners who are live on care quality to test and to describe how would we actually exchange unstructured images and notes, because we know that's going to be the next level of unlock that's going to be available for providers and the care team. And then I'd say the last thing that the NextGen customers can expect is just better routing and rules around notifying you of new document availability. If everything that we release, if every update that we make introduces some new alerts or some new workflow, pings and notifications and 5 new elements here and 7 new elements there, it makes it actually very hard for providers to cut the noise, right, and find the signal from that noise. So in all of our interop services, we're working to provide better and more minimal number of notifications, right? Smarter alerts that tell you not only do you have a new document, but it only matters if that new document contains something that you didn't know about. And not just anything you didn't know about, but something that's relevant to your clinical practice. So we're trying to use better tools to identify the things that are more meaningful to individual users. And that's going to be different by specialty and care setting. So customers can look forward to us asking a lot of questions in that vein so we can tease out what are the potential solutions.
Yeah, and that's going to be so important. We'll talk about it a little bit later in the presentation, but we're making a lot of progress with getting data where it needs to be, and this next battle of making it effortless to be able to and intuitive and useful is really where the battlegrounds are.
And a lot of this is really going to have to come from people just joining on and giving that feedback, right? To say, here are the things that we need, and also coming together to say, as an industry, this is highly unstructured and it's really hard to share this information back and forth. Can we put some more rigor behind this? And so that's where it's kind of cool to see. You look on this chart on the right-hand side, you see the progress that some vendors are making in terms of getting adoption with this type of connection, getting more and more customers to use this data. That just continues to put fuel on that fire. So, you know, being able to see NextGen go from that, what was that, 3% up to like 33% just in a couple of years. We're excited to continue to see that growth. Hopefully there's a couple folks on the call right now who haven't adopted that. And this is something that prompts you to look at it, because the validation we've had from customers is this is immensely valuable. If you're able to pull that information in and have it come through, it's low effort to set this up. There's no additional cost to do this. And so there's a lot of upside to be had. And the more the people connect, the more data that you're able to tap into. So it's not only get me connected, but can I encourage other people to get connected in as well? So this again gets to another question. So you guys had that good uptick, you know, you got up to that 33, 35%, you know, tick around 2020. Where is NextGen adopting right now?
Yeah, right now I think we've ticked up a little bit more. I think the pandemic maybe encouraged customers to activate more interoperability services. So I think we're at the 45% mark right now on care quality adoption across the NextGen Share user base. Now we still have a lot more work to do, right? There's an approach that we took, which maybe is different than some of the other vendors, where other vendors, I think, turned it on by default. One of the things that we heard from our client base, especially around, you know, if you think about the types of customers that we have a ton of FQHC customers and behavioral health customers and organizations that have multiple specialties in-house, especially those that deal with, you know, mental health. We thought it would be prudent to put the ball in the customer's court to decide about activation, if they were ready, if they'd set up the right rules and the right routing, and the right controls around consent and other items. So we've encouraged customers to upgrade. And I think just over this last, you know, pandemic year, we've seen an increase in clients who need to reach out and get data from other sources. And I think that has definitely encouraged adoption. It's an open question about whether or not we will, you know, activate care quality on behalf of everyone at some point. That's not the approach we've taken in the past. Rather, it's an educational and an informative approach, so that it's not just a question about whether or not you turn on care quality or not. But what we found is it's more than just that binary of yes or no, I'm active or inactive, but it's whether or not you've turned it on and you've optimized the flow of the content. Because just having it on by itself, you know, certainly will tell you when new data has arrived or not. But it doesn't mean that users in the organization have embraced the flow of that data, that they found, you know, it part of their normal and daily and active clinical, you know, care for a patient. And so one of the things that we've done is taken a more educational route to inform and optimize the activation of these services with customers. And I think that has proven to be successful, because it's not just an issue of, you know, turning it on and leaving it and forgetting about it, but turning it on and actively using it, we found to be a more important metric.
Yeah, for sure. And that's I'm glad to hear you say you're working with customers on that, because this is something, one of the kind of subtle points that came out from this research is it just takes a while to get used to doing interoperability and to get really comfortable with it. So if you're used to just working on your own, having your own records and not having to use anything else from outside your organization, there's a question of, do I trust that someone documented things well? Is this going to be just garbage in that's going to distract from my notes? Do I have this built in my workflow where I have to take that extra step to look at the data? There's a lot that goes into it. It's not something that's just real easy. So it does take some thought, and it does take some practice. But we have seen, again, as we've looked at some of those more advanced users with this research, the benefits really are there. And people are starting to say, yeah, we are so glad that we started down this road.
Yeah, and as you guys as vendors take barriers out of the way, that seems to speed things up, right? So you've taken the barrier, you've made it easy, and it's not expensive. And then even as providers make their decisions, you know, anything that is there anything you guys are doing as far as, you talk about educating, so are you bringing forward, you know, hey, this is how others have done it? And because I know there's oftentimes a lot of concerns, and you talk about FQHCs and some of the behavioral health around the privacy and the level of, you know, what can and can't be done. And one of the early problems we saw, one of the things we saw early on is that everybody was kind of left to figure that out for themselves. And so, you know, you go into whatever legal department, you know how fast legal departments oftentimes move. So are you doing stuff around that to kind of help streamline that so everybody doesn't have to figure it out on their own?
Yeah, absolutely. And, you know, because as you said, Corey, I mean, early on, the fear was, you know, folks thought that if they turned on care quality, they were basically opening up, you know, a global search engine on their patient population. And that immediately, you know, was just a huge concern for people to want to close their arms around it and say, no, thank you, I don't want to participate. But as folks started realizing that, no, there was a lot more controls that organizations actually have, we were trying to disseminate some of that information around like how best practices, you know, how do you record consent? How do you enforce consent? How do you notify patients that they even have the option to opt out, right? How do you inform your providers, right, about identifying certain items inside a clinical note that they don't want to share, right? So certain elements in a note or certain encounters today can be marked as sensitive encounters, and those on a configuration basis can be excluded from all care quality exchanges. And so we, as a vendor, had to introduce some of those tools before some customers would activate the service. And just because of the nature of the NextGen enterprise EHR, where we can have an enterprise that includes multiple practices and multiple locations, we had to provide controls at the practice level to allow customers to opt out perhaps of one practice while allowing the data sharing of all of the other practices. So those tools have been introduced and now available, and we've had to know, you know, the customers who were maybe on the fence a while back, you know, should now feel more confident to know that we have those exchange tools that allow you to limit and control the amount and the, you know, the depth of the data sharing that can happen across these exchanges. And I think as more people learn about that, their comfort level with this will grow, because it's not, as you said, Corey, earlier, it's not just it can't be, interoperability can't just be an afterthought or something you slap on, you know, or something that you just add. It has to be a core part of how patient care, you know, is delivered. And we think these tools make that easier.
That's awesome. Well, and to get into what you were talking about before around behavioral health, this is something near and dear to my heart, just given the research that I cover around behavioral health. But as we look at the post-acute and behavioral health market, this space has seen a much slower adoption of connecting into common home care quality. One, just from a vendor perspective, even having the connection available, but also just from customers being willing to do that. Again, because there are legitimate concerns around how is this information getting sent out? Am I going to be putting out information that really shouldn't be? So we see adoption really has been quite limited. And as you look at the vendors here, yeah, there's a good number who are connected, but that purple bar kind of shows here's where, you know, most multi-specialty vendors like a NextGen are connected. Yeah, on average, that's the average bar there. And every other post-acute behavioral health vendor falls below that in terms of how much have we adopted. So it's definitely something where if you're connecting in and trying to share information with post-acute or behavioral health organizations, there's a lot less who are doing this. But important caveat to this is it is something that we have validated. The organizations are saying we have seen benefits from this, and this is something that we think needs to continue and to progress. In research we did in 2018, most organizations in the post-acute space were saying, yeah, we do a lot of faxes. Maybe we'll go log into someone else's EMR remotely to kind of look at the information we need, or some are connecting into HIEs, but a lot of that is kind of it's heavy work to utilize that data. But you see that quote there at the bottom where someone talks about this is useful and it's growing. This is something that we're excited about. So these are early adopters. So we expect them to continue to push things. But if you are in this space or know people in this space, being able to look and see there might be something here for us. There are legitimate concerns you need to work through. Make sure you're working with your vendor, understand what parameters have they put in place. But it's definitely something where it's becoming a reality. And so check to see if your vendor has, if, you know, as you're working with NextGen, what does that look like for me? Is it something that we can leverage today and feel like we're safe?
Yeah, and if you've got an important post-acute provider in your area that you need to connect with, again, many of the major EHRs in the post-acute space have some level of connection into that national network. but very few of those of their customers are actually adopted at this point. But it might be worth having a conversation to understand if their vendor does that, and maybe encourage them to connect, because that's a much easier and a less expensive way than trying to build out like a some sort of a point-to-point interface.
Absolutely.
Okay, well, so we'll shift gears a little bit here. So the other report we did in 2020 was around general progress with interoperability. So we've done a series of reports. We did one in 2016 and 2017, and we noticed that there was not a lot of progress if we measured it every year. So we took a few years off and came back and measured it. And what this is measuring, so this is a little different than the reports we talked about before, which were focused on only on the advanced users. This is general population, right? So we just went out and talked with a certain number of each of the EHR vendors' customers. We didn't, we didn't get pointed to the most advanced users, but we just went out and we talked to them about their interoperability experience, and really trying to understand how effective was it. So we call it deep interoperability. I think the first time we did this report, we call it a home run, right? So we use a baseball analogy, but then we do a fair amount of research outside of the United States, and we found that analogy didn't translate very well outside of the United States. So we switched to deep interoperability, but really what it's looking at is, do we have access to data from outside sources? Is it easy to find in my record, right? So is it in a place in my record that makes it pretty easy for me? Do they do things to actually put it in my clinical workflow, right? So is it not just someplace where I can find it, but it's actually, there's some sort of a workflow enhancement to it. And then the money question on this is, does it impact patient care to the extent that it should have, right? So it's not just does it impact, but does it have the impact that it should? And what you notice is on the left-hand side where we've got it circled, again, you can see we've made tremendous progress in the amount of data that is flowing, right? So in 2017, only 28% of the folks we talked to said that that they had the data available, right? That it was in my record somewhere. It didn't matter if it was easy or anything, but it was just there, right? So I'd gotten the information from outside sources, and we jumped all the way up to almost 70% said that, yeah, we're getting the data. So we're starting to take down the barriers of getting data from one place to the next. But you can see it kind of drops down. And so the way to read this chart is that where it drops down is of those that if you have it in your record, and then you also have it in it's easy to find, right? Then that drops down to 44%. So there's another, what, 23% or so that have it in there, but they're like, it's still really hard. It takes a lot of effort for me to go and find it. So but again, making progress, and then stuff to actually enhance and put it in the clinical workflow. Again, making progress. So typically, if it was in there and easy to find, the majority of those had been starting to pull that out and put it into the workflow. But then you notice that there's a pretty significant drop off when it says to have it's having the impact that it should. And this goes back to something that Mo talked about earlier, was that you can't just flip it on, right? So you think about that, you've got 38% that they have data, it's in the workflow. You would think, okay, we're there, right? But it was interesting how many customers we talked to that were a lot like in fact, I think, let me see if I can go back. Let's try this one. No, wrong way. So if we go back here, you look at this long-term care quote, and it says, yeah, it was there. It was it was pretty easy to set up. It's beneficial, right? We can do it, but clinicians have to access it as well, right? The clinicians have to be used to using it. And so oftentimes what we would hear is, yeah, we've got it there, but our clinicians just aren't trained to really understand how to do it, or they're still a little bit leery about it. And so one of the important things we're finding is that helping clinicians, and that's the question we wanted to get to here, is helping clinicians get to the point where they're comfortable and they're actually hungry for it, because we've seen that in those that have been live and been using and exchanging records for a longer time. They actually shift from where it's kind of a natural progression to be a little leery to get to the point where you're like, oh my gosh, just get it in my record. I'll figure, I trust what's happening. I know how to use it. And so Mo, as we go to you, what sort of things are you guys doing specifically around to kind of help the clinicians become comfortable trusting the data and getting them to the point where they're actually hungry for more data?
Yeah, I think our responsibility is to get the technology out of the way, right? To make it like usable in such a way that it feels like a natural activity. It feels like a normal thing to do. For example, on the record review process, records that have been exchanged, received across care quality, if they're in that custom view, if they come into the chart at the right time and are available to the right person, perhaps it just becomes a natural step. For example, a patient who's been checked in and they're with the medical assistant before the physician comes in, couldn't that be the right time for a person to review a medication list received from outside, right? Wouldn't that be the right time to reconcile any of the clinical content that is available across the care quality network? So we have to make sure that the technology doesn't slow the organization down. The document should already be available. It should be easy and fast to pull up. It should be responsive when a user wants to compare the external medication list to the one in the EHR or the problem list or the lab results. And so we have to make sure that these things just work. And for the end user, it doesn't matter if, it shouldn't matter if the content is richly coded or not, or if it's obviously we want compliant CCDAs and compliant documents, but for the end user, all of that is irrelevant. Does it work or does it not work? And so we have to make sure that our systems are robust enough to support that, and that the automation is set up in such a way that the documents are delivered early enough that they can actually influence a care decision. Because if somebody's reviewing a medication list that's been exchanged after the patient has left the office or after the telehealth visit, it's a huge opportunity that's missed, right? And in fact, it creates a lot of, especially for things around, test and test results, it creates a lot of patient anxiety if they don't have that content. Like, I was admitted to the hospital, I saw a physician, I had a test performed, and now I'm at my primary care physician's office. I want to make sure, I need to believe, and it's very important to me that primary care physician has access to all of the things that happened when the patient was at the hospital. And I expect the provider to have access to it. And so for us as a vendor, it's important to make sure that the technology doesn't get in the way, but just make sure those documents are delivered at the time that they're available. And to the question about comfort, right? To the question about how can we make sure that the organization trusts it, it only takes one instance where a patient says to the doctor, hey, I was at the hospital, you should have access to that record, and that data doesn't show up or isn't available because there was no patient match, or the system didn't fire in time, or what have you, for the provider to say, forget it, this doesn't work, I'm just going to pick up the phone, or I'm going to log into the hospital's portal, or what have you, I'm going to wait for the fax, right? And so it's really important that interoperability, which historically was not seen as a mission critical component, right, was just kind of, like you said, an afterthought, that we treat it like a mission critical component that it actually is, so that we don't have a situation where people are clicking and not finding results, because that's the worst case scenario and will absolutely turn people off. So we have to get out of the way and just make sure that it just works, because it's that's the only thing that builds up the trust and comfort, I believe.
Yeah, and it's interesting how hard trust and confidence is to build, and how quickly it can go away with a bad experience that way.
Yeah, I mean, we've all experienced that, right? Where you open up a record, you say, hey, I think it should be there, right? I should be able to click and retrieve a copy of this record, and nothing shows up, right? And that's where the trust gets broken, and we lose, that opportunity to share the information that's available.
One of the things, Mo, that we know is, again, helping the organization get organized, or helping them kind of set up their workflows. You talked about this, right? Having the right person do the reconciliation at the right time, and not pushing it all up to the end of the road, and having the, you know, the actual physician doing everything. How are you guys going about some of the change management pieces to help the organizations to actually do that, right? Because that's re-engineering their workflow at that point.
Yeah, and you know, honestly, this is an area that I think is still an emerging opportunity for us. Like, we have historically maybe just over the last year or so shifted our thinking a little bit, where in the past it would have been enough for us just to say, oh, a customer turned on care quality, right? Or turned on direct messaging, or turned on an HIE interface. And that binary question of on or off was really kind of the only metric that we really were honed in on. But now, as we've evolved our thinking across our entire service organization, that it's not just a matter of yes or no, but of actual usage, number of documents exchanged, number of clinical reconciliation events, right? Number of users who are interacting with this external data. These are all metrics that we're now tracking. And so we can look at a customer's account and find out, you know, are they actively heavily using the system, or are they just passive users? Because that's also a bad indicator. If you're just a passive user where you have it on, but it's just for outside systems to benefit from your data, that's good. And that's not a bad thing, but there's also an opportunity to improve the actual customer engagement. So we're now tracking the usability, and we're working with our account management and professional services team to help describe, you know, an engagement to get customers from passive to active users, right? So that, like you said, it's not just about turning a service on, but actually implementing and, you know, and benefiting from it. It's a process. And so even though most vendors, and this is true for us also, these services are free, right? There's no charge to turn on care quality, but there's a cost for the customer to redesign or update their process. And so it's not something that we had, I would say, really truly, you know, like done a deep dive to understand how we actualize turning on a service to actually optimizing it. Just in the last year, we've shifted our thinking now that we've seen customers who are heavier users have a better experience across all of the other NextGen services that are complementary to this. So that's where we've shifted our thinking. And for customers who have a question about their own usage, you know, talk to your account manager, talk to your, you know, client care representative to see, you know, if there's something that we can help, you know, as part of that survey and investigation.
Yeah, and I think that's important to know that, you know, again, this is much more than just turning on. The technology pieces are getting better, and I think they're oftentimes ahead of where we are in the adoption and the, you know, really using them. And so, you know, don't try to, if you're a provider out there, don't try to figure this out on your own. Leverage somebody that's been through it before and get some help. That'll speed up your success quite a bit with it. One of the things in that last report is as the conversation has shifted a little bit around APIs are coming up a lot more. Everybody talks about FHIR, right? And that is becoming more and more front and center. And so we started to ask in this last study, for the first time, we started asking about, you know, how providers were using APIs. And we asked them, you know, what are you using? How are you intentionally trying to use them, right? So APIs facilitate a lot of stuff in the background, right? That's how a lot of stuff happens. But what we're talking about with APIs now in interoperability is that you can intentionally take either an application that you're building, or you've got a third-party application, and plug it into the API. So an API, if you think about it, is kind of like the outlet that you plug your computer into, right? That is all a standard. You plug into that. Your system is set up to manage and take the voltage that's coming out of that. And you don't have to think about it. You don't have to go and say, okay, oh, I've got to twist 3 wires down and do this over here before I plug this device in. And then when I plug another device, I do something different. You just plug it in, right? And so that's the hope around APIs, is that they become and help to facilitate a much more, not only plug and play, but also a much more granular, structured exchange of data. So Mo talked earlier about, you know, we get big unstructured things that are coming across, and there's only a small amount of it right now that's structured in the CCDA. And so it makes it challenging to use some of things like notes and all of those types of things. But with FHIR, And in the APIs, you can request something specific like a blood pressure or an age or something along that lines, right? You're asking for a specific piece of information. But really what we found, and again, the summary of this is that we're early on in the adoption of these. But it's likely going to become a bigger part of what we're doing long term. And so I just ask you, what do you guys see? How are you guys looking at APIs? What do you see them playing for your customers? And then specifically, what do you think about FHIR, and where's FHIR going to fit into that?
Yeah, absolutely. I think APIs are an accelerator for us, for our customers, for third-party partners that we want to work with, for partners that want to work with us. And for our tech savvy clients, who want to benefit from their own data in new and interesting ways, APIs are an accelerator for them as well, right? Historically, clients, before the API, the advent of the API, clients would write their own, SQL scripts, right? And stored procedures to do work or to get data out of their system or just interact with their practice management or EHR environment. So that would be on them to set up and manage and control and then update those same procedures and queries when the next version of the EHR comes out and breaks everything that they did in the past. The API standardizes all that and says, no, there's one front door to get data into and out of the system, and it's uniform and it's standard and it's RESTful and it's secure. And hey, it's updated, right? So we'll automatically keep it updated as versions of the EHR change. So it makes things easier to connect. But like any new standard, it introduces a new standard, right? And a new way of doing business. So we're really excited about FHIR. I think there are tremendous opportunities for patients, who now have access to clinical content, on their phones through FHIR-enabled apps. That's awesome for patients to be empowered with their data across multiple health systems. Because, at NextGen, we recognize, we're an ambulatory EHR. So we're one part of a bigger care setting. And so that FHIR enablement across systems is going to be really powerful. And the vendor that unlocks that, I think, will also unlock a tremendous amount of opportunity for their users. So that, for us, FHIR is a way to do that. Now, today, we have a FHIR API for patient access that's enabled across the EHR, and customers can turn on today. And we're updating the NextGen Enterprise API for support of a FHIR protocol alongside that, an R4 FHIR protocol alongside the NextGen Enterprise API. It's a new way of doing business. I think will standardize a lot of data access. Most importantly, I think for third-party services and third-party partners that can extend the functionality of EHRs and PM systems and patient portals. So I think we've always taken the approach of letting 1,000 flowers bloom and not really building a walled garden and closing it off. NextGen has always been a very open platform to work with. And this is just another example of us doing the same.
Yeah. And it'll be interesting to kind of see how those kind of end up speeding up innovation as we go forward, because I think that's what everybody's hope is. So I just wanted to just pull out a few lessons learned that we thought would be helpful for everybody to consider as you think about interoperability. And what we've learned through some of the reports that we've done. And so we just put down, I think the connection from Commonwealth to care quality that Tyson mentioned earlier, we think that's a super important thing that happened in the industry. And that initially those two entities kind of started off on different sides of the fence. They kind of had, it was almost like lines drawn in the sand, but they've come together and kind of just did what was right for the industry and connected, which was huge. That as you adopt interoperability, realize that there's barriers, and I would encourage you to leverage your vendor. If you're working with NextGen, go to NextGen, get their help in taking down some of those barriers and speeding up your progress and your success. And then the last thing is, it's just going to realize it's going to take some time. So it's not very often that we hear about people turning on and say, oh man, it was just magic and everything was wonderful. They have to kind of learn and get used to it and grow in that comfort. But I think as you spend some time on the people part of this, right? The training and the processes and the different things around it seems to be a key to people having success and value in it. So, but Tyson, let's let you jump in. We'll let you talk a little bit about some of the information blocking stuff.
Yeah, so hopefully this is somewhat relevant given the rules that are coming down the pike. But we did some research kind of asking provider organizations, about information blocking. What were their perceptions around it? So for those in the crowd, I would imagine a good majority of you probably feel like you're pretty prepared for this. We've seen this across all different vendors. About 70% of providers feel, yeah, we think we're prepared. And a lot of that, you look at that chart below. 75% of customers say, yeah, we are very confident in our vendor's compliance. And I think that's a big part of what drives that confidence, is saying, do I trust that my vendor knows what the rules are and can be able to comply with that? That helps put a lot of people's mind at ease. But one of the things that really causes some of that uncertainty is really around the vagueness of the rule, right? Because you can say, oh, well, if you charge too much, it's information blocking. Well, how much is too much? What are we talking about specifically there? Or if you take too long to provide information, it's information blocking. How long is too long? And so as we talk with provider organizations, that was really the biggest question that they had is, do I really understand this? Those who felt like they understood it, were more in the minority. There's a good number who say, yeah, I think I understand. I think I have a good handle on it. But you could see a good half of people who say, maybe, I think, I hope. And that's where you kind of have to be able to lean on your vendor to provide that expertise to say, yes, we know what's going to be happening. So it'll be interesting seeing what happens moving forward. As we talk with organizations, this is really interesting because the whole purpose of the information blocking rule is to really help move interoperability forward. Let's open up the data. Let's make it available. And there's, again, you kind of flip a coin to see, is this going to make a difference in people's minds? Some say, absolutely. Having some hard rules to finally push people to do the things they need to, that's going to be working. And, being able to leverage APIs, do the things that Mo's talked about, absolutely, that's going to move things forward. But then there's other people who say, well, I don't really understand all the specifics of how this will really be rolled out because things are kind of vague. And there's a lot of loopholes and other things that people could try to leverage to get out of this. So we're not sure. So a good chunk are unsure. Some are pessimistic, and you're always going to have some varying opinions, but it'll be really interesting to see what the impact of it is. And so that's where, again, coming back to you, Mo, we're just looking to see, as you think about information blocking and the confidence that you're trying to get from your customers and what you're doing there, what is NextGen doing to help customers be able to understand what those requirements are and be able to meet them?
Well, I think just as you've identified, I mean, the rule is complicated. It's very long. There's a lot of different elements to it. And, folks have a lot of questions. So we've really been organizing around our Health Reform Simplified webinar series and our success community. The NextGen, portal for clients has a ton of information about information blocking resources, information blocking tools, access to NextGen staff, physicians and regulatory folks who can answer questions. And really what we're doing also is, from a certification perspective, preparing our EHR for certification, and not just our EHR, but our interop tools as well. And so there's that work that's going into the certification effort that's happening later this year. So it's across the entire organization, making sure that customers have information about information blocking, what it means to them, what are the tools that they need to have in place so that they can be open and accessible and not be subject to any penalties later on. And a lot of that is about policy and procedure. Some of it is about technology, but it's almost all requires education first, right? And learning, where the rubber meets the road for you and for ambulatory customers. And so for customers who are on the line, I highly encourage you to check out the Health Reform Simplified webinar series. The next one is coming up later this month. So register for that, because a lot of excellent content about the rules and what it means to you. And all the previous recordings are also available on Success Community.
Great.
All right, so I think wrapping it up, what is, Mo, I guess we'll ask you, where do you stand? So are we going to make it, or is interoperability going to get to where it needs to be?
Yeah, absolutely. I've always been an optimist, and I actually like George Carlin's stance on this question. You know, it's not half full, it's not half empty. It's twice as large as it needs to be, right? So it's the wrong size. And I think, you know, it's just a different way of framing it, right? Like I think it took a lot of effort to get to where we are right now with these national networks and organizations, putting aside their competitive edge and saying, no, we're going to work with other vendors. That's what interoperability is all about. And I've always really loved that part of this part of healthcare, where for me and my peers, like we don't care about which competitor is doing what. We want to make sure our system works well with everyone. And if everybody else has that same approach, then we can actually accomplish really heavy problems for patients and for providers. And I'm really excited about where things are going. I think systems becoming more open is a net good thing for patients. And we always kind of, it's almost a cliche now to say, yeah, but we're all patients, right? And that's true. We are all patients. But when you're actually, in a hospital or being treated or waiting for an anxious test result, the rubber really meets the road for you on a very personal level about whether or not your provider has access to the data, that you have access to the data, that you can be engaged if you want to be. And so this is all very real in a sense that, we have a lot of good that we can do. And I see us as an industry, especially with these APIs and the opening up of systems, moving forward and hopefully delivering for patients. The big hairy questions about, who pays for it and, how do we incentivize it? Those are not answered yet, right? And those are not completely defined, but generally I feel very positive and optimistic about interoperability and patient access more generally. So, and I hope in your research, you find the same. And I think you've seen that the industry has slowly but surely crept along, hopefully in the right direction. And we're glad to be a part of it.
Yeah, and I think we feel largely the same way. And you think about, again, interoperability being that offensive line of healthcare. You cannot have a successful offense. Your quarterback, doesn't matter how good your quarterback is or how fast your receivers are or how good your running back is. If your offensive line doesn't do what it needs to do, none of the other pieces work. And it's one of those necessities. And we see the conversations changing and the kind of the sentiment around it changing to where it just is picking up momentum. I think we're pretty bullish on the future and are excited for it as well. And I think that's it. Katie, I know we only have a few minutes left here, but happy to take any questions if there are some.
Great, thank you so much, Corey, Tyson, Mo. That was wonderful. A question did come in around the CCDA document. Does NextGen consider whether the proper CCDA document is being used? For example, a referral CCDA has the data already arranged to be most effective for a referral. Does the common view take all of the proper document types and put them into a single view that isn't structured?
That's a really great question. And today the custom view is really it's a custom view that is filterable and configurable, but that filtering and configuration doesn't take into account, the specific CCDA type. So the filters are around things like quantity of data, right? So if you received a longitudinal CCDA, you could apply a filter that says, only show me the last, 6 encounters, right? Or the last 3 months of data, or filter out all of the inactive medications. But there's no filter today that is custom for, let's say, a referral CCDA versus, let's say, a history and physical CCDA or a discharge CCDA. That's a really great idea, though, and something that I think I can certainly take back to the development team. I don't know, though, where the rubber meets the road for users, that an individual user will necessarily know the difference between history and physical CCDA versus a referral CCDA, unless we tell them, unless we show them, by the way, this is a specific type of document. And we don't explicitly do that today, but maybe that's an opportunity for us to do it, to really show that, yeah, there's some thought that went into what was sent to you. So good question. I don't know that we have a perfect way of answering that or delivering it today, but something we can take back.
Thank you so much. We are right at the top of the hour. I want to be mindful of everyone's time. We have recorded. There's been a few questions about will the recording be sent out? And yes, within the next few days, the recording will be sent out. I want to thank all of our panelists for a wonderful conversation. I want to thank everyone who joined us. If you have any follow-up questions, please feel free to respond to any of the emails that you've received about this webinar, and we'll definitely get back to you. Thank you so much to all who participated, and have a wonderful rest of the day.
All right.
Thank you.
Thank you all. Bye-bye.